Okay guys, we're going live in about 1 minute, so hang tight. Less than a minute and we'll go live. If you guys cannot hear me, somebody please let me know. I'm going to start by just going through some stuff that I pulled together, and then I will take a minute every now and then and answer your guys' questions. Okay, so it's 2 o'clock. So I was asked by several people yesterday after a video I posted to address how to pick the right OBGYN. And so this is my 2 cents for what it's worth. And I just want to let you guys know, I am a double board certified obstetrician gynecologist, and I also do a high-risk obstetrics. So I'm a maternal fetal medicine specialist. So all of my patients are high-risk pregnancies for either maternal and or fetal reasons. But that's all I do all day, every day. So I also work with general OBGYNs. So most of what I'm going to talk about is how I think people should go about picking an obstetrician or someone who's going to deliver a baby. And this is if you're already pregnant, early pregnant, or thinking about conceiving. So the first thing I want to talk about is get referrals. What does that mean? So there's many ways you can kind of find out about doctors. You can go online and get referrals that way because the web is a great place to find out about doctors. The second place would be to ask friends. Friends know who they like, they know who they don't like, and for what reasons. And the third place I would say is if you have any doctors, either in your family or in your social circle, always ask them, because even if they're not obstetricians, they may know who they've heard of that is very good based on their own patients or their own personal experience. I get asked nearly daily about who I recommend in my local area and then also across the nation. And I have a lot of people I know across the nation, but then there's ways that I can research and ask through friends and colleagues as well as who they would recommend. So word of mouth means a lot. I also want to caution, when you go online and look for a doctor, patient reviews. Everybody looks at patient reviews and everybody puts a lot of weight into patient reviews. I have to be honest, I don't think they're accurate for the most part because there's no way to tell if a patient got mad or someone did something maliciously, and there are plenty of phenomenal doctors, both obstetricians and not, that I know, I've seen their work, I know they do great, and they get slammed on the internet. It could just be from one person, and so there's no way to know how accurate that is. So I would take patient reviews online with a grain of salt. The biggest resource you have is, like I said, friends of friends, family. If you have a physician in the family, that's the best way to start asking about who is recommended in your area. Then you need to kind of decide what kind of doctor do you want? Who do you want to take care of your pregnancy and your delivery? We have general OBGYNs like myself, which I don't do general OBGYN practice. I'm a high-risk obstetrician, but I am trained to be a general OBGYN. So those are doctors, MDs or DOs, people who went through training to be an obstetrician and deliver babies regularly. I also support midwives in a freestanding birth center that is accredited. It needs to be accredited. I personally work on a labor and delivery unit in an academic center where the midwife service delivers on the labor and delivery unit. So they're independent of me, but they're working right alongside me. Should something go wrong, they can consult me immediately. If the baby's having issues, the mom's having issues, the mom gets sick, the baby needs they need a C-section, they're right there in the hospital and delivering. So there are ways to have midwife deliveries, my recommendations are in a freestanding accredited birth center or in a hospital setting, or through an obstetrician gynecologist, MD, DO, that is their practice. I won't go into all the other stuff. I am an academician, I am an MD, and that's what I recommend. So you kind of decide where you lie, what kind of obstetrician do you want. The next thing you need to do is research whoever you pick, research their credentials. So you can ask them personally. You can look online to see where they were trained. You can look online to see if they're board certified. Board certified means this: when someone finishes medical school and goes through, and I'm going to use OBGYN as a reference because that's what I do. So I went through 4 years of obstetrics and gynecology residency training. Once a person has done that training, they are allowed to go out and practice on their own. However, we have to pass 2 sets of board examinations. The first is a written board exam after we graduate the 4 years of residency. Then within a certain amount of time, they need to do another board exam, and that is an oral board exam, and that means they become board certified, okay? After they pass their written exam, they are board eligible. After they pass the written exam and the oral exam, they are board certified. That means they've done a lot of studying. They have been vetted by the ABOG, or the American Board of Obstetricians and Gynecologists, and that means they are considered qualified to practice OBGYN. I personally think it's very important that your obstetrician be board certified, okay? There are other ways to vet midwives. I am not as familiar with how to do that, so you'd have to find that out on your own, or ask somebody who knows better than me what their credentialing is. But again, I will reiterate that I support freestanding birth centers with certified nurse midwives, or CNMs is what they're called, or midwives who deliver in a hospital setting along the MDs, medical doctors such as myself, but again, they're still independent and they use us if they need us. So, you need to, there's ways to find out whether or not your obstetrician has had lawsuits against them or anything like that. You can do all that online. Find out where they trained, and again, if they're board certified. And then more important, or not as importantly, for me, it's not as important. The gender of my obstetrician was not important. For some women, it is important, and they prefer a female for whatever reason, and that's fine. So obviously you need to know the sex of the doctor when you're researching whether or not you want female, male, or it doesn't matter. Years of experience. So, that's kind of tricky in a way, because I know plenty of amazing doctors that have under 5 years of experience. And there's something to be said for an obstetrician who is kind of a fresh graduate, because they are up to date on the newest information, and likely practicing what we consider evidence-based medicine, which is what I do as an academic obstetrician or maternal fetal medicine specialist. So don't discount someone because they've only been out for a little while. The likelihood is, if they're in private practice as an OBGYN, the seniors in their practice are, supervising them and making sure that they're doing okay. And that's the whole purpose when you go into a practice like that, is you have senior obstetricians who are guiding you. Obviously, the more years of experience, you have more experience at how to deal with things, and it's fine. But I just don't discount the ones that are kind of what we consider new graduates, which would be like 5 years or under. It's always, you might want to get more information about them from your friend or family referrals. So pick a practice. So pick a practice means, right now, most OBGYN practices are in a partnership, meaning there are multiple OBGYNs in a group, or they're owned by a hospital and they're a hospital group. It's not as common to find an OBGYN who is practicing by his or herself, just because it's not easy, and it's a very difficult quality of life if you're the only doctor, because you're responsible for all your patients and you're on call a lot. So that's why obstetricians are, for the most part, in group practices, and I fully support that. It would be extremely hard to be the only one who's responsible and being available 24/7 to deliver all of your patients. So there's also practices where they have MDs and midwives that work alongside each other, like where I work. So in our situation, women who are low risk can go to the midwife service, and if they develop an issue, they can hop on over to my service. So there's also services like that. You can look at, if you're looking at a birth center, again, I support freestanding accredited birth centers or midwives who practice in a hospital alongside the MDs. So there are ways to vet them as well. You could always go in, take a look, ask questions to vet them that way. So when you're picking an OBGYN, there's different routes you can go. You may decide based on location, where the physician is what's important to you. You may decide that the hospital where you would deliver is the most important thing. Or you may decide that the actual physician is the most important thing. So you kind of have to decide what comes first. the actual physician, the hospital you're going to deliver at, or the location. It's very different across the nation as far as how close women are to hospitals and their doctors. So you kind of have to decide what is more important to you. For example, the doctor that you really not like may not deliver at the hospital you really like. So sometimes you have to pick. So you pick a hospital that you really like and then look and see which doctors deliver there and decide that way. So you kind of need to decide what is most important to you. So that's kind of one way to stratify when you start researching obstetricians. Once you've picked, if you pick based on the doctor and then you go to the hospital they deliver at, you can also research the hospital. What is the hospital like? For example, there are a lot of hospitals who have very high qualified NICUs for those women that have complications and deliver early. And then there are hospitals whose nurseries are not equipped to handle a baby under 35 weeks. So if there's an issue and you need to be delivered early, they may transfer you to a different hospital. In a lot of areas of the United States, you don't have a lot to choose from and you have to go to the hospital that's closest to you, and if you have a complication, you get transferred. In my area where I work, that happens a lot because we have patients from hundreds of miles away and they go to the initial hospital that hospital can't handle because there is a likelihood she may deliver early or has a complication early, so they ship her to us where our NICU can handle that. So knowing what the nursery capabilities are, should you have a complication, is important too. Don't be surprised if your hospital says, you know what, if you have a problem under 35 weeks and we think there's a chance you're going to deliver, we're going to have to transfer you to this hospital. So it's important to ask that up front so you can be prepared. Or if you have the ability to make the decision to go to deliver at another hospital where you wouldn't have to be transferred, you have time to do that as well. There are situations where you deliver at the hospital, the baby has an issue, and the baby has to be transferred, and you may or may not be able to go with the baby. Again, there are areas of the country where women don't have a choice because there's just not a lot of hospitals around. But then there's other areas where you do have a choice. So knowing what the nursery or NICU capabilities are at the hospital you choose is important, so that you could A, choose a different hospital to deliver at, or B, know ahead of time what might happen should you deliver early, or once you deliver, the baby has complications and may have to be transferred out. And a lot of women don't think about that, and I get it, and that's perfectly normal, but it is an important thing to find out when you're looking to decide where you're going to deliver. So the one area you can also start out when you're looking is what your insurance is. You can call your insurance company and say, which providers take my insurance? That's one way to start and one way to weed it out, because there's a lot to choose from. Where does my hospital, what's in network? Going out of network is not always fun because it can cause a lot of issues with your insurance company. So you may just want to call your insurance company and get a list of the obstetricians or midwives that are covered by your insurance company. And then also, once you are pregnant and you're going through the process, knowing what costs are going to be expected up front or through the course, or what the package is, it's always better to be prepared, in my opinion, and know what your insurance coverage is. I want to take a minute to just say, very importantly, there are many women who are on Medicaid, and most of my patients are on Medicaid. 90+% of my patients are on Medicaid. That does not mean you have to, or you're going to be subjected or have to receive a lower quality of care. There are many doctors who accept Medicaid who do excellent care. Okay, so I don't want anyone to expect that because you're on Medicaid that you're not going to get the best care. That's simply not true. Now, in some areas, that may be the case, but don't accept less than excellent medical care if you're pregnant and on Medicaid. Okay, and I also encourage every woman, whether you're on any kind of insurance, private insurance or Medicaid or what, ask questions. You are entitled to ask questions at any point in time. And if something happens in your pregnancy and you don't understand what's happening, you need to ask. I will digress for a second and say, I've been taking care of pregnant women for 20 years, and it never ceases to amaze me. Women who have come in and had complications in their pregnancy, or had surgeries in their pregnancy, or cesarean sections, and they don't know why. To me, I don't understand that. How could you have had a C-section, don't really know why? You got to ask questions, okay? And sometimes it's because the doctor doesn't explain well, and sometimes because it's the patient didn't ask questions. So it's a two-way street. Make sure you are always aware of what's happening to you and why. Okay, that's my my little piece on that. I'm going to take a second and see if anybody ask any questions. Any of you guys that are on, you can ask questions. I don't think anybody has because I've been watching for a little bit. Everybody said, okay, hang on. Okay. So nobody's asked questions. So I will continue. Go back up. All right. On to the next topic. You know, it's also important to consider what your health history is. If you have, okay, so difference between Jesse, Pants, 5677, difference between MFM and REI. Okay, so I'll take a minute to explain. We go through 4 years of OBGYN residency training. We can stop after the 4 years and become a general obstetrician and gynecologist, where we do a mix of obstetrics and gynecology. Or we can go on to do subspecializations. But subspecialization means you can go and do additional training to, number one, be a maternal fetal medicine specialist. That is what I do. That means I deal with all high-risk pregnancies, and that's all that I do, where the mom and or the baby have issues. You could go on to subspecialize in reproductive endocrinology and infertility. That is REI. Okay? REIs are the ones who do IVF, IUIs, fertility issues. They see women when they're trying to get pregnant, or they can do surgeries on women that are having trouble conceiving or other issues related to endocrinology and infertility. And then there's also gynecology oncology, or gyn-onc. Those docs go on to subspecialize in female cancer surgery. So they don't do any OB, okay? The REIs can do OB once their patient gets pregnant, up to, they usually keep them until about 12 weeks, okay? 10 to 12 weeks. And then the gynecologists, oncologists are all doing female cancer surgery, and they only deal with women who have female cancers, female-related cancers. Okay, so I hope that answers your question. Let me go back. That would be 30 weeks to HR. So, Lakshmi, she is saying that she delivered her baby at 34 weeks due to IUGR. What precautions should I take while choosing my doc when I plan? No, so for just, and I only going by what you told me, just for IUGR, which happens, that is intrauterine growth restriction, where the baby's not growing like it should. You could go see your OBGYN, but if you're going to see a new one, make sure you get the records from your previous delivery so that your next doc will know exactly what happened with your pregnancy. And then they can determine whether or not seeing a maternal fetal medicine specialist is indicated. If you are not pregnant and you're considering another pregnancy, you could always see an MFM in preconceptual consultation. That means before you get pregnant, you can talk to an MFM about what happened with your last pregnancy to determine if anything needs to be done differently with your next one. I also want to say that it is perfectly within reason. If you had a complication in your past pregnancy, or you have medical issues and you are desiring to become pregnant, you are allowed, and insurance will cover, a preconceptual MFM, maternal fetal medicine consultation visit, where we can look at your pregnancy history, your medical history, and let you know what we think needs to be done before you get pregnant. It's always better to do that than to wait until you're pregnant, because we may want to do other additional testing. We may want to get you better controlled on whatever medical condition you have. We love to see preconceptional consults, because that means we can work on you before you actually get pregnant, rather than seeing you once you get pregnant and we're trying to play catch up with whatever medical issue you have. So always remember, you can always see an MFM and for a preconceptual visit. Let's see, where was I going? Back to your health history. So if you have complications, you typically, when women, once they're pregnant, it's typical for them to see an OBGYN first, okay? And then the OBGYN determines if they do have medical issues that are pre-existing, should they go see an MFM. If you are not pregnant yet and you have you think about it, go see, like I said, an MFM for a preconceptual visit, so we can determine whether or not your diabetes, high blood pressure, lupus, kidney disease, whatever heart disease is under control, and whether or not pregnancy is recommended, okay? So based on that, that's where MFMs come into play. So an OBGYN, if they see a patient who has a medical history that is significant, they can either A, take care of it themselves if they feel comfortable, B, consult a maternal fetal medicine specialist to help co-manage and give recommendations on how to manage the pregnancy, or C, if the patient is too complicated for them, and there are patients that are, they could say, you know what, it's better that you see a maternal fetal medicine specialist throughout your pregnancy and be delivered by them. So those are 3 routes where an OB/GYN and MFM come together. Either you have a medical issue or issues, and the general OB/GYN takes care of it themselves. They consult MFM to help them co-manage, or B or C, they completely turn over care to an MFM. Go to the next question. As an MFM, do you ever see patients who have no complications or are not high risk? I'm applying to med school and soon would love to be an OB/GYN. So no, I mean, if it's someone's low risk, we usually don't see them unless there's an issue, okay? Abnormal genetic testing or on their abnormal antenatal screening. They're diabetic, have a high blood pressure, lupus, renal disease, kidney transplant, previous complicated surgeries, previous uterine or ovarian surgery that would be important for the next pregnancy. I mean, there could be anything that's the mom has any medical condition that might affect the pregnancy. That's why we would see them. Or there's the baby has a defect or a medical condition or is not growing properly, or there's a placenta previa, or there's something like that where an MFM is needed for either consultation or complete management of the patient. So no, I don't see the completely low risk patients. When I might see them is when they're in labor and they start having complications on the midwife service, and then they turn over care to me, and that's when I take over low risk patients. So that does happen. Okay. I had my first baby at 39 via IVF. My husband and I are planning to do another transfer next year sometime. Can I still stick to my current OB? Yeah, so we're gonna, just a little info about 40 and above. 40 and above, you are at increased risk for certain things based on age alone, no matter how healthy you are. I know women don't like to be considered advanced maternal age or geriatric or whatever, and the terminology, listen, the terminology sucks, but it's the best that we have, okay? But whether you're healthy or not, at age 40, you are still, based on age alone, an increased risk for certain complications in your pregnancy. Those things can be managed by an OB/GYN. If they determine that they don't want to manage you or don't feel comfortable managing you or need help from an MFM for whatever reason, then they can ask for an MFM's help. So yes, Rainbow Mama, after infertility, you can stick with your OB/GYN, but ask them, do you feel me being 40 is going to be any more complicated? Do you think I need to see an MFM or have a visit with an MFM? And it all depends on your doctor's comfort level and how they, if they want an MFM's help. So, what do you know? I don't know. So no, Jessie Pants, we're not going to get into metformin. Maybe another discussion. So if there's certain things you guys want to know about and I can't get them to them today, private message me and we'll do other topics, okay? Let's see. All right, I'm going to move along. So your health history does matter. And, talking to your doctor, your general OB/GYN, you can ask them, hey, if something happens in my pregnancy and I'm complicated, what maternal fetal medicine specialist do you refer to or use? Because all OB/GYNs should have those MFM docs that they use. They may be in the same center or hospital where you're delivering. They may not. Depends on, there are areas of the country where there's not an MFM for a while or far away. But asking that up front, if I have a complication, what do you do, is important to ask. We talked about some of the women know there's always this process. Let's see what I might come back. Okay, sorry guys, I'm looking at my laptop because I want to make sure I don't miss anything. Okay, I'm going to go to now what questions you should ask your doctor. Asking them how long they've been in practice. Where did you get your training? How many babies do you deliver each week? There are some general OB/GYNs who do some OB or obstetrics, but they mostly do GYN, and that generally happens as they get older in their practice. So, it's okay to ask them. You may decide that you would rather have someone that does OB or delivers obstetrics a little bit more. But asking them how many they deliver compared to their partners, or if they have partners who do obstetrics more, is a perfectly reasonable question to ask. You can also ask, who will see me during my prenatal visits? You need to ask that because in general OBGYN practices, Dr. X may be your doctor, your assigned doctor. But if you go in for your prenatal visit and Dr. X has to go do another delivery or is stuck in surgery for whatever reason, who's going to see you? In most practices, either another doctor in the practice will see you, or some practices have physician assistants or nurse practitioners who will see patients in the doctor's absence. So knowing who will see you throughout your prenatal care is important. Like, who could possibly be seeing me? Every practice is a little bit different. And I will tell you right now, in most practices, because these doctors are very busy, the chance that your doctor is going to see you at every prenatal visit for the entire pregnancy is very slim. They try their best, but you have to understand they have a lot of things. Obstetrics is so unpredictable. They may have an office day and then end up being stuck in the OR all day because they had a difficult case. And we have to, as women, when we're pregnant, we get very, scared, we are emotional, we want the best, and we want to see our doctors, we get attached to our doctors, but we have to give them a little bit of a break. Remember that, because they're doing the best that they can. I know OBs love to see their patients and they know how important it is to us, but we have to cut them a little bit of slack if they get pulled to do something else, okay? They're doing the best that they can, and hopefully that won't be a routine thing, but it may happen more than once throughout your prenatal care. And then also, how often do you get seen? In an otherwise normal pregnancy, you are seen every 4 weeks up to 28 weeks, every 2 weeks from 28 weeks to 36 weeks, and then every week from 36 weeks until delivery. So that's the general routine prenatal care. If you are complicated or have other issues, then you might be seen more frequently. So the basics are that every 4 weeks to 28 weeks, every 2 weeks from 28 weeks to 36 weeks, then every week after 36 weeks. Okay. So the whole thing, let's talk a little bit about birth plans. I'm not opposed to birth plans as long as you're okay if things don't go exactly as planned. Just because it is put on paper does not mean it's going to happen or does not mean it has to happen. What the whole purpose of a birth plan is so that your physician knows what you desire and you discuss that with your doctor ahead of time. Don't whip out a birth plan when you go in labor and spring it on your doctor. That your birth plan is something that if you're someone who wants a birth plan, some women don't. I didn't, but some women don't. But if you're somebody who wants a birth plan, it's a process that starts over time. Okay, so work on it, work it out with your doctor as you go along, so that you guys, their doctor can tell you what they can honor, what I call can honor, and what they cannot honor, or what they can compromise on. Just because it's written down on the internet does not mean your doctor has to do it, okay? Because I'm going to tell you guys, there's a lot on the internet that is not, what's the right word? I don't want to make anybody mad, which is not reasonable in my opinion. That doesn't mean I don't accept birth plans. It means that you need to talk to your doctor so that you know what they can and cannot do, and they have time to explain to you why they can or cannot do it, or why they are asking you to compromise. Coming in with your birth plan in hand on the day that you deliver is not the time to discuss your birth plan. It absolutely is not. And I also want women to know this. Ladies, if your birth plan does not happen for whatever reason, it does not mean you failed. It does not mean you failed. I feel like so many times I see a woman has a birth plan and it didn't go as planned for whatever reason, and they beat themselves up so bad because they think it's their fault, or they did something wrong because it was written down and it didn't happen. We can't do that to ourselves, okay? Childbirth I would love for it to be predictable. It would make my job a lot easier, but it's not always predictable, okay? So my thing about the birth plan is it's a process over the course of your pregnancy. Talk to your doctor as you go along. Let your birth plan evolve over time so that when it gets close to your delivery, you have a birth plan that you guys both understand, your doctor is not surprised about, and that you know this is what we're going to try our best to do. I hope that makes sense. So a birth plan, XD, is basically what a woman desires during her labor and delivery process, anywhere from Pitocin to epidural to skin to skin to, there's a whole bunch of things, a peanut ball, laboring in different positions, a bunch of things. I mean, women, I also see this while we're on the birth plan topic. They'll go and download a birth plan off the internet and stick it in my face, but they don't even understand what the birth plan means. They just thought because someone else put it on the internet that that's what a birth plan is supposed to be. You need to know what it means, okay? Because if I tell you, I'm trying to go through the birth plan and you don't even get it, that's a problem in itself, okay? And I can tell when patients just copied something off the internet without really understanding what they were doing. Because then what happens is if I tell them this isn't reasonable, then they think I'm wrong or that I'm not being reasonable. When in reality, it's a birth plan that came off the internet that somebody put together and you don't even know who that person is. So please trust your doctors, ladies, and gentlemen, if there's any gentlemen. We have to start with a trusting relationship, and we can't assume that the doctor can't be trusted because something that was on the internet your doctor doesn't agree with, okay? You have to, if the trust is not there like that in that respect, then it's going to be an issue throughout the course of your pregnancy, okay? Okay. The whole thing about a doula. So a doula is someone who's kind of like, that comes in and helps you throughout the course of your pregnancy and labor and delivery, and it's kind of like support for you. They tend to know a lot about, laboring in different positions, things to relax. They know some things, some of them know things about lactation and breastfeeding. I don't, because most of my patients are high risk, I don't work with doulas a lot because they're high risk, and it's, these deliveries are, high risk deliveries. So, but you can, doulas there are a lot of amazing doulas out there. So you can always research those on the internet and also ask friends and family. Okay. Let me go back, and there's a lot of questions here. So let me scroll back. Bear with me, guys. Hold on. So exo die, I just turned 30, not yet ready to conceive. Do I need to worry about fertility and higher risks? So just in a nutshell, and this is a whole nother live discussion. So if you want to private message me that discussion, I'll be happy to put that on my list of things to do. Generally, after age 35 is considered high risk for two reasons. Number one, egg quality. That means the eggs are of a poor quality starting at age 35, then dramatically after age 37, and then it takes a nosedive after age 30. Quality means where the chromosomes within the egg start to stick together or don't function like they should when the egg and sperm join and the chromosomes are supposed to replicate and separate. It just doesn't happen because you're born with all the eggs you will ever have, and they sit in your body for however long until they're ultimately used. Whereas men's sperm, and I may be a little bit off this, sperm are produced every 72 hours. So they always have new sperm. We don't always have new eggs. So age does affect egg quality. That's why you hear an increased risk of women having Down syndrome as they get older, because the egg quality is decreased. You also hear about women having an increased risk of miscarriage because the egg quality has decreased. So when the egg fertilizes a sperm, there are chromosomal defects within that embryo, and then women of an older age are at increased risk for miscarriage because the egg and the sperm did not join correctly. The second thing is egg quantity. How many eggs we have available to fertilize decreases starting at age 37 and takes a nosedive after age 40, okay? So I caution women that are young and they don't see, let me back up. There is no reason why you have to be in a hurry to have kids, as long as you're informed about the consequences of waiting, okay? You're age 30, you're already thinking about it, okay? So if you think it's gonna be a while, you might be getting into your late 30s or 40s, you might consider freezing your eggs. You may not ever use them, but it's a little bit of an insurance policy. But at age 30, there is no reason why at every visit you can't talk to your OBGYN about your child planning or your family planning, how long you're wanting to wait, so that you can be aware. I will just let you guys know, most of you probably know who follow me on social media. I was perfectly healthy. I married at 39, had a miscarriage right before my 40th birthday. By 40 and a half, I was going through 5 cycles of IVF. I had no normal eggs, but one out of the 5 cycles, and that one did not take, okay? All of my eggs, the quality and quantity of my eggs by age 40 had taken a nosedive. I ultimately got pregnant because I used donor eggs. okay? So while I am an advocate for women having babies later in life, I am also an advocate for being informed and knowing the consequences of waiting, okay? So I don't want women thinking that, oh, I have infinite amount of time to get pregnant, because that is simply not true, okay? I don't want women thinking, well, my mom had a baby at 47. My aunt had a baby at 48. My sister had a baby at 43, so I'll be fine. That is not true. Egg quality and quantity are not genetically predisposed. That means based on what your mom's history of having babies and all that doesn't matter. You need to know your body and be informed and all along, so that you know as you get further out into your 30s and even 40s, you've got to know about the consequences of waiting. One other thing, and then I'm going to move on. IVF. I hear all the time from women, well, if I can't get pregnant on my own, I'll just use IVF. IVF did not work for me. IVF does not work for everyone. IVF is not a valid plan B for every woman. You guys have to know that as well. I had to go through 5 cycles of IVF and then egg donor to get pregnant, okay? So IVF did not work for me. So I'm not trying to scare anybody. I'm trying to educate. You have to be educated on your body, the consequences of waiting. But, you know, again, we don't have to have babies in our 20s anymore. You can have babies later in life, and more women are having babies later in life. A lot more women are delaying childbearing. A lot more women are having babies in their late 30s and 40s. But a lot more women are also using IVF to do so, or other forms of assisted reproductive technology, which includes IVF, IUI, all the other ways to get pregnant with the help of a fertility specialist. So you have to keep that in mind. Okay, I'm gonna go down to another question. Can you change if you feel uncomfortable with your current doctor? Absolutely. I will tell you, some doctors don't like to take patients later in their pregnancy. So if you're considering changing, do it sooner than later. You will first have to find a doctor who's willing to take you. I don't know how far along you are, Lily Ann, 2003, but if I will caution you, the later you wait, there are some OBGYNs that won't take patients further into the pregnancy. So if you're interested in changing your doctor, I would start looking now. Okay, I would want to do this. Okay, Summer Sweetie. I'm 29 weeks pregnant. Is it too late to change my doctor? My doctor's better. Okay, so I would love to say no, but I don't know where you live. I don't know the doctors in your area. Again, like I just said for the person above you, if you're considering changing your doctor, you need to do it now, because again, there are doctors who will not take patients past a certain gestational age. They won't take them on as a new patient past a certain gestational age. So you need to start looking now if you're wanting to change. Yes, bedside manner is very important. It is. But I will also say this. There are some doctors that don't have the best bedside manner, but they're awesome doctors. I will tell you, I have a couple of friends that I know that are colleagues that don't have the best bedside manner, but if I had a complication, I would take them over anybody. But that's also knowing all different sides to them. So it's hard. It's hard to find a doctor that has a fabulous bedside manner and is a fabulous doctor. I mean, it's harder. It's not impossible. It can be hard. And there's been times in my life as a woman where I've picked expertise over bedside manner. But I wish I didn't have to, and I wish you guys didn't have to. So I'm not saying that you have to pick a doctor that is just awful bedside manner, but sometimes also the ones that have the best bedside manner are the best ones in general too. So you just have to kind of decide, what's important to you. And again, that's why establishing prenatal care or seeing a doc before you even get pregnant is so important, so that you can know about that doctor and get to know them. Okay. Getting to know a new doctor when you're pregnant it's hard, especially if you don't mesh with that doctor. So, I would give it a few visits, and if you don't mesh, you got to find somebody else, because the sooner you change, the better. Okay. Okay. Yes, it is. We talked about the birth plan. I'm pondering, considering. Okay. If you, Gillian, if you want an epidural, can you tell that to your doctor on the day of labor, or does it have to be? No. We're going to talk about questions. I'm going to answer a few more questions, and we're going to talk about questions. No, at some point in your pregnancy, usually around the 34 to 36 week mark, the practices should be asking you what you're desiring. It's talking a little bit about, what your birth desires are as far as epidural. But no, you don't have to tell it does not have to be documented in a birth plan. Most doctors should be asking you at some point later in your pregnancy whether or not you're wanting to do an epidural. Okay. So did you have a doctor who listens, understand your worries? Trust. Okay, does IUGR prematurity repeat in second pregnancy? Can we test soon enough? No, so does IUGR the biggest predictor of preterm birth in a current pregnancy is a prior history of preterm birth. IUGR is not necessarily the same, but it's good for us to know, okay? So your question is IUGR prematurity repeat in a second pregnancy? It can, absolutely. Premature delivery is more likely to, but it can. What are the chances of repetition, and can MFM test soon enough before it's too late? So, we have to look at your prior pregnancy history and determine what plan we're going to come up with in your current pregnancy based on your prior pregnancy. And that I can't speak for other MFMs. I know how I handle, preterm history, preterm delivery, and IUGR. And I'm not going to go into that here, but it's important that you let your doctor know so that they can determine if they're going to change your plan or your management at all in your current pregnancy. So freezing your eggs, does that mean they're better quality? So if you freeze eggs, they cannot test them. The ideal time to freeze your eggs is between about 26 and 32, okay? That means because the genetic component is less likely to happen, and also you get more eggs. The younger you are, the stimulation your ovaries get with the medications you're taking is much better, and you're more likely to get a lot more eggs to freeze. You want to freeze in volume to have a better chance once you do decide to use them, that you have more eggs to choose, or more eggs to use, okay? So because they can't genetically test an egg before they freeze it, okay? Me being African American, so I'm 38, my high risk is. So yes, being African American and advanced maternal age does place you at a higher risk for certain things. Absolutely, it does. So it's good that you know that and you're aware of that, and you can ask your doctor. That doesn't. Let me back up. So it doesn't mean that you have to be labeled high risk. That means your doctor needs to know that about you and respect that about you, and be on high alert for the things that are increased risk for African American women and being of advanced maternal age, okay? So I also don't want women walking around feeling like they have a scarlet high risk on their chest either, okay? It's important to recognize, but that I don't want them to get in the mindset that you're going to have complications, okay? But you also have to advocate for yourself. You got to be an advocate for yourself. The best thing you can do is ask questions and ask for explanations, okay? It's the best thing you can do in your pregnancy. Prior freezing, please say the life so I can listen to. Are you at work for me? Miscarriage? Okay, where I live. Thanks for answering my question. I live in New York. Yes, totally. Can IVF cause preterm delivery every time? No, that's not true. No, that's not accurate, okay? All right, I'm gonna move on to some other questions. We talked about the birth plan. So what should I expect? Question you can ask your doc, what should I expect during my labor and delivery? So again, the whole labor and delivery process varies. Knowing which hospital you're going to deliver at is important. Knowing who's going to manage your labor and delivery. Your labor. For example, in some places, the doctor does not come in unless there's a complication or you're close to delivering. The nurses manage your labor. It depends, whether it's daytime or nighttime too. Knowing also the practice, who's going to deliver me is also an important question to ask, because if they're in a group practice, your doctor may not be on call the day you come in labor. Unless it's a scheduled induction, they schedule you on a day that they're going to be on call. So knowing who could potentially deliver you is important, okay? Knowing about the hospital, knowing about, when can I get an epidural? What typically do you do for epidural? Do you wait till I'm certain centimeters dilated? What are my options for epidural? I will also let you guys know that in some hospitals, anesthesia and OB or the obstetrician are not in-house 24/7, meaning they're not in the hospital 24/7. So they get called in when certain things are done. So what is the wait time if I want an epidural, if they're not there 24/7? Where I work, high-risk OB, or myself, MFM, covers labor and delivery 24/7. That's not typical. And also we have OB anesthesia there 24/7, but that's because we deliver mostly high-risk patients. Not all hospitals have anesthesia or the obstetrician in the hospital 24/7. So knowing that up front is also important. Knowing about induction of labor. When do you ask your doctor, do you induce my labor? How far will you let me go before you will induce me if I don't go into labor on my own? Whether or not they do operative deliveries. An operative delivery is a forceps or a vacuum delivery. I do not do forceps. I do vacuum deliveries, okay? You know, under what circumstances would you do a forceps or a vacuum? You know, if you do them. Episiotomies. Episiotomies is where they cut the perineum. The perineum is the area between the vaginal opening and the rectum, that thick piece of skin there. Sometimes we cut episiotomies to make more room because, especially on women who have not had babies before, I've done this a long time. I can tell when the baby's getting close to coming out that if I don't give her a little bit of room, she's going to tear in a lot of different places. And sometimes you can control the tearing a little bit with experience, and I've had a lot of experience. I've been doing this for 20 years with an episiotomy. In order to keep the woman from having massive tears everywhere else. So, you know, should every woman with every delivery be getting an episiotomy? Not unless it's indicated. I mean, not unless there's a reason. So asking your doctor about an episiotomy is important. Asking what you can do for pain relief. When can I get my epidural? You know, when do I typically get my epidural? If I need something before I get my epidural, what do you do? There are certain medications we can do through the IV until you get to the point where you want the epidural. So asking your doctor about that. Who will be in the hospital during my labor? Meaning, like I said, are you going to be there 24/7? Would it potentially be one of your partners? Does the nurse manage my labor until I get close and then you come in? How does it work? Again, when will the doctor be present? At what point in time will the doctor be there in my labor course? If the baby has issues after delivery, like I mentioned earlier, can the nursery at this hospital handle my baby, or we have to transfer the baby somewhere else? There's a lot of times where the babies get transferred to my hospital because they got delivered somewhere else and the baby has an issue, and mom may or may not be able to go with them. And sometimes mom can come with them. And sometimes another family member will come with the baby, and the mom and them get separated. So knowing about what happens if there's a complication with your baby is important. So the whole thing's about, we're actually going to do an Instagram live session, not Instagram, YouTube live session soon on labor and delivery questions. So I'm not going to go much more into the whole labor and delivery. Again, we talked about who will deliver my baby, who is responsible for my labor and delivery if you're not available, or my prenatal care if you're not available. And, you know, if you're out of town, when will you be on vacation? When will you be out of town? So who covers you if you're absent for vacation or other reasons? Who would potentially deliver me if I'm not, if you're not on? Would it be one of your partners? You know, asking all that is important. And again, give your docs a little bit of a break. There's a lot of babies being born, and they cannot, for most docs, they can't promise you that they're going to be there for your delivery. It might end up being one of their partners. If that's the case, meet their partners. Have a couple of prenatal visits with them so you get to know them, and you won't have met them when you first go in for your delivery. So if you're at a practice where, whoever's on call delivers you, should you go into, early labor a little bit early before your due date, get to know their partners and have a couple of prenatal visits with them so that you know them and you will have met them. Let me go answer some questions. If your mother had multiple miscarriages, does that mean you're at higher risk? I've been told this and doesn't know why. So it depends on why your mother had multiple miscarriages. If it's because of a clotting disorder, blood clotting disorder, then yes, you need to know that, okay? Especially if your mom has had blood clots in the past. If you have any first degree relative, mother, sister, brother, dad, that's first degree relatives who have had multiple blood clots, especially at an early age, you need to let your doctor know, even if it's your first pregnancy, okay? If your mother had multiple miscarriages and she also happened to have a history of blood clots, let them know, but not necessarily. Miscarriages, it can happen for multiple reasons. Unless you know exactly why your mom had miscarriages, I can't really tell you, other than the whole blood clotting thing, if that would place you at higher risk. Okay, let's see. Another important question is C-sections, knowing, and we can also do another session on that, talk to your doctor about C-sections, under what circumstance might I need a C-section, what happens if something urgent happens and I need a C-section. There's a lot of things that can be predicted. For example, if you're diabetic and the baby's big, going way past your due date. I will tell you, there's new information out right now, and at my center, we offer elective induction of labor for everyone at 39 weeks. They do not have to accept that, but we do offer it. We have found in a recent study that it doesn't increase complications or increase the rate of cesarean birth in these women. So we do offer elective induction of labor at 39 weeks. We only deliver before 39 weeks if it's medically indicated. That's a whole nother topic too. Just because a patient's tired of being pregnant, and it happens, I'm not saying that to be mean, it happens. We deliver only if there's a medical reason to do a delivery before 39 weeks. Okay. Also ask your doc what kind of breastfeeding support. And I say this with, it is so important in those first few days after you deliver to have someone available that knows about lactation and can tell you if your baby is getting enough food or milk, okay? Because especially if you're a new mom and you haven't done this before, it can be hard to know how much your baby is getting, and you don't want your baby to get dehydrated. There's a big movement towards exclusively breastfeeding, and I completely respect that. I was not able to breastfeed my twins because they were in the NICU for 3 weeks. I pumped exclusively, and they got only breast milk for about the first 7 months of their life, and then breast milk supplemented with formula up until about 10 months, and after that formula. So everybody's different, okay? I fully support breastfeeding. I think it's wonderful, but if you can't, fed is best. I'm gonna say it. I don't care if anybody gets mad at me. Fed is best, whatever it takes. If you can breastfeed, I fully support that 100%, but making sure a baby is fed and hydrated is the most important thing, no matter how that is accomplished. That's all I want to say about breastfeeding. So asking your doctor about what support you have. They offer in the hospital after you deliver, and those first 48 hours is very important to help you learn about latching on and all of this about, educating get as much education as you can about breastfeeding. Another important thing to ask is if you have had a previous cesarean section in another pregnancy, and you desire to have a trial of labor after cesarean, you need to ask your doctor if they do that, because some doctors don't and some hospitals don't. So be prepared for that. If having a trial of labor after cesarean, if you are a good candidate, and I only support trial of labor after cesarean, that's a whole other topic as well. If you are a good candidate, okay? There are some women who are not good candidates for trial of labor after cesarean, and I have no problem saying that. There are some women who absolutely are not the best candidates for trial of labor, but there are many who are. However, based on whatever reason, your doctor and or the hospital where your doctor delivers does not allow them. If that's the case, then you might need to find a doctor and hospital who do allow them if that's something that you want. And that's all I'll say about that. Also asking your doctor, if I have a problem during office hours, who do I call? If I have a problem on the nights or weekends, where do I call? Where do I go? Which hospital do I go to if I have a problem? What else? So I'm going to say a little bit about prenatal vitamins right now. If you are of reproductive age, whether you are finished childbearing, you think you finished childbearing, you're contemplating childbearing, just take a prenatal vitamin. Take it every day. Even if you're not intending pregnancy, as long as you have a uterus, you could potentially get pregnant, and it's okay. Prenatal vitamins are not going to hurt you. So for those that are unintended pregnancies, which are surprise pregnancies, already having prenatal vitamin on board is perfect. Make sure that prenatal vitamin has at least 800 micrograms of folic acid, okay? Most prenatal vitamins have 1 milligram, but they need to at least have 800 micrograms of folic acid. Just start taking it, even if you don't think you are going to get pregnant. It's important to already have that on board. Also asking your doctor what antenatal classes or childbirth, parenting what antenatal classes on childbirth and parenting do you offer through the hospital or in your practice. There are a lot of antenatal classes available, and taking them is great. I actually, even though I delivered babies my entire life before I had, got pregnant with twins and had them almost at 43, I wish I had taken some, because I'm going to tell you, I thought I was pretty smart until I had kids, and then I realized I'm not that smart. This shit is hard. So if there are childbirth classes available, parenting classes available, take it, because it's not going to hurt you. Okay, it's not going to hurt you. Okay, let's see, what other questions? Can I request an elective cesarean section? You can. Their ACOG does support requesting an elective primary cesarean section. That means you can request a cesarean section without any medical indication. That's considered an elective primary cesarean section. Once you have had a prior cesarean section, you are entitled to have an elective repeat, or you can do a trial of labor if you are a good candidate. But as far as the elective primary, you can't ask for that. My only caution to that is, and I do honor it, after I counsel the patient, listen, if you're gonna planning on having 2 or 3 more kids after this, that would not be my recommendation. I'll honor it, but that would not be my recommendation, because you keep adding C-section on C-section on C-section, then the complications start to accumulate, especially by that 3rd, 4th, and 5th C-section, okay? So make sure you have the conversation with your doctor if you're desiring an elective primary C-section, so that they can have that conversation with you and make sure you're making the right decision, okay? I was actually my mother. My mom nearly died. Let's see. What's the best way to find out about your fertility before getting pregnant? So, what's the best way to find out about your fertility before getting pregnant? Seeing general OBGYNs are wonderful, okay? But as a woman who delayed childbearing and as a woman who went through fertility issues, if you're wanting to get an accurate, thorough assessment of your fertility in one fell swoop, you need to see a reproductive endocrinology and infertility specialist, or an REI doc. That's what they do all day, every day. They assess women's fertility and they help women get pregnant, and they deal with other reproductive issues. That is what they do. So if you want to get an accurate assessment, that would be my recommendation. I'm not in no way discounting general OB/GYNs. There are some things they can do, but what I see all the time is they'll do some part of the workup, and then patients most of the time end up going to an REI anyway. So if you're wanting to get your fertility assessed, my recommendation is go straight to an REI for it. Maria Love, I'm not sure, you said which one do you recommend? If you're talking about prenatal vitamin, it doesn't matter, girl. Any prenatal vitamin, and somebody asked about DHA as well. Taking a capsule of the DHA is fine too with your prenatal vitamin. Let me go back down. I don't know what happened here. Oh, there we go. REI, Exodi, DYE, reproductive fertility and endocrinology specialist. I'm 40 and have a phobia of childbirth. How can I get over this fear? I don't know why. I mean, it depends on why, hun. If this is you've never been pregnant before, or if you've had babies before and something traumatized you, it all depends. I think if it's a true, first of all, take the first scenario. If you are 40 and you've had children and you're traumatized from it, that is called birth trauma. That is a real thing where women, for whatever reason, I have 2 minutes left before it's going to shut me off, where they have trauma in their childbirth, and that can be, a little bit of what we call, you can get PTSD from your delivery or whatever happened. So see a therapist. If you have not had babies and you have this fear, I don't know. I would still see a therapist, because maybe they can pull that out of you and figure out what's going on. All right, I think it's going to answer all the questions. I'm going to stop here because I want to be able to, let's see what this was. Okay, I hope I got to answer most of the questions here. I'm going to stop this so I can save it. Otherwise, it's going to cut me off. Sporty Red, I'm not going to have anybody join me in this video. If you want to private message me after this, please feel free to do so. That's all the time I have. Thank you. I'm going to try to post this live. Hopefully I can save it. But anyway, if you guys want other topics and want to ask me questions, private message me and I'll try to do some more videos. Have a great day. I'm trying to do this and save it, but